Enteropathic arthritis is a form of inflammatory arthritis that's linked to diseases that affect the bowel, specifically inflammatory bowel diseases, IBD, like Crohn's disease or ulcerative colitis. It's important to note that IBD is different from irritable bowel syndrome or IBS. In enteropathic arthritis, joint symptoms often emerge during a flare of the IBD. Though some individuals, these joint issues seem to occur independently. When the inflammation from enteropathic arthritis is active, individuals experience joint pain, swelling, redness, warmth, and a limitation to their range of movement from stiffness. These symptoms are commonly seen in the larger joints like the hips and the knees. It falls under a broader category of seronegative spondyloarthritis. There are several subtypes in this area, such as psoriatic arthritis and ankylosing spondylitis. They don't have a specific antibody that is linked to them, and a characteristic that they all share is enthesitis, which is inflammation at the tendons and ligaments at the point at which they join to the bone. For someone to have a diagnosis of enteropathic arthritis, they usually must have to have been established to have a diagnosis of inflammatory bowel disease like Crohn's or ulcerative colitis. Although it can develop at any stage, it typically occurs to people between the ages of 20 and 40. Any child under the age of 16 who is diagnosed with an inflammatory arthritis and has IBD will be diagnosed with juvenile idiopathic arthritis. The condition seems to affect men and women equally, though it's more common in people with Crohn's disease as opposed to other types of inflammatory bowel disease. While it's less common than rheumatoid arthritis, affecting perhaps between 1 in 1,000 and 1 in 5,000, it seems more prevalent in Europe and North America. It's essential for people with inflammatory bowel disease to be screened for features of inflammatory arthritis. What causes this? Well, it's believed to stem from an overactive immune response, particularly related to inflammation that starts from the gut, but the exact cause is still unclear. What is understood is that there's likely to be a genetic predisposition in people who have inflammatory bowel disease and arthritis. This is then triggered by an event, which could be an infection, and this then leads to the immune system to mistakenly attack the body's own tissues. In this case, it can be targeted towards the intestinal lining, leading to inflammation and damage. The gut can become swollen and inflamed, and chemicals called cytokines are released, which recruit more immune cells to the area. The gut can become leaky, allowing proteins, chemicals, or even microbes to enter the bloodstream. And this can start a perpetual cycle of inflammation that goes on to involve the joints. The cytokines that we've seen are similar to those in rheumatoid and include things like anti-TNF, IL-6, IL-12 and IL-23. The joint symptoms can differ greatly from one person to another, and the severity doesn't always correlate to the amount of underlying inflammatory bowel disease. For most people, though, the joint symptoms do settle down once the inflammatory bowel disease is well controlled. When it comes to diagnosing enteropathic arthritis, the typical process begins by seeing a gastroenterologist or potentially a general practitioner. Once it's been suspected, a referral to a rheumatologist is made for further evaluation, though in some private healthcare settings patients may go directly to the rheumatologist. The diagnosis is based in the majority on the story or medical history, questions about other conditions, the medications you take, allergies, and any relevant family medical history will be asked. What follows is a detailed examination, looking for signs of joint inflammation such as swelling, warmth and tenderness. They may also inquire about gastrointestinal symptoms and other features that might suggest inflammatory arthritis such as skin rashes or problems within the eyes or even the presence of back pain. Once the initial assessment has been done, a series of investigations will likely be requested. This usually includes blood tests to look for markers of inflammation like the C-reactive protein or erythrocyte sedimentation rate or ESR. It's common to have specific antibodies checked like rheumatoid factor and CCB also requested, although they're likely to be negative as this is a seronegative arthritis. If the bowel symptoms are active, a stool sample or a poo sample may be requested, partly to rule out an infection, but also to pick out an inflammatory marker called calprotectin. In some cases, a genetic test may be done called HLA-B27, which is associated with seronegative arthritis. Imaging studies like X-rays, an MRI or an ultrasound can help look for signs of inflammation. Sometimes the ultrasound may be performed in the clinic. In some rare cases, joint fluid may be taken and analysed to look for crystals, or even a biopsy taken of the joint lining. When it comes to managing enteropathic arthritis, the most important treatment usually starts by controlling the underlying inflammatory bowel disease. In many cases, if the inflammatory bowel disease is properly managed and brought under control, the arthritis will also improve. Alongside medical treatment, lifestyle changes can play an important role in managing enteropathic arthritis. This could include looking at dietary adjustments, but also understanding how to protect the joints. And you may be offered education from physiotherapists or occupational therapists to maintain joint strength and mobility. Support from a dietitian may be useful. When it comes to medication, treatment plans are typically coordinated between the rheumatologist and the gastroenterologist. Although non-steroidal anti-inflammatory drugs can be helpful in relieving joint inflammation, they're often not well tolerated in individuals who have IBD. In some cases, disease-modifying anti-rheumatic drugs may be needed. Several drugs may be combined to treat enteropathic arthritis, such as sulfasalazine, methotrexate, or azathioprine. These are effective in both conditions. Biological DMARDs can be used to treat underlying colitis, but in some countries these aren't licensed for the use of the arthritis. In conclusion, enteropathic arthritis can be a challenging condition. It's important to understand that managing the underlying bowel inflammation often leads to improvement in all the joint symptoms. Regular monitoring and a collaborative approach between the specialists, as well as lifestyle modifications, can all contribute to a better quality of life for people living with this condition.